Today we'll be discussing about otosclerosis. What is otosclerosis? Auto means ear, sclerosis means abnormal hardening. So abnormal hardening of the bone of the ear is known as otosclerosis. So you know that the aortic capsule, the inner ear, has a bony labyrinth and a membranous labyrinth. The bony labyrinth forms the cover, and inside you have the membranous labyrinth composed of the utricle, saccule, semicircular canals, and cochlea. And the bony labyrinth covers the membranous labyrinth. The membranous labyrinth contains endolymph, and between the membranous labyrinth and the bony labyrinth, there is perilymph. And the bony labyrinth is having three layers. It has an endosteal layer, that is the innermost layer, then an enchondral layer that develops in the cartilage, and a periosteal layer. This is a general anatomy for understanding otosclerosis. So what happens is the normal enchondral bone of the aortic capsule is replaced initially by spongy bone, and then this hardens to become a sclerotic facet, that is otosclerosis. So where does this happen? So we know that the enchondral layer develops embryologically from cartilage. So there are some cartilage rests, the embryological cartilage rests that can remain in the aortic capsule areas, that is known as foci of interossi. These can act as a foci for initiation of the development of otosclerosis. So the initial lesion occurs at an area between the oval window and the cochleariform process known as a fistula antifenestrum. So anteriorly, this fistula antifenestrum is there. So there it starts, and it can spread to the other parts. It is believed that these embryological cell rests are present in this area. Also, the first histological sign is known as blue mantle. That is, there is a change in the extracellular staining pattern. When this abnormal sclerosis of bone happens, what happens is the staples that is getting attached to the oval window will get fixed. So the staples mobility is affected and the patient will have hearing loss. That is the problem with otosclerosis. In our entire body, all the bone is getting remodeled. That is, the old bone is replaced and new bone is laid. That is done by the osteoclast and the osteoblast cells. So remember that osteoclast contains C, so osteoclast clears the bone. Osteoblast contains B, so osteoblast builds the bone. This bone turnover and remodeling goes on happening. But in aortic capsule, that is a petrous temporal bone, this bony remodeling is very, very low, almost absent. This is mainly because during the bone remodeling, various enzymes are released, and these enzymes can be harmful to the inner ear. So the aortic capsule bone turnover is very, very low. But what happens in otosclerosis is this bone turnover mechanism is disrupted. So there are multiple reasons for that. The main thing that happens is there is an enzyme known as osteoprogerin. So this is known as OPG, and RANK ligand and RANK. The RANK is receptor activator of nuclear kappa B. The RANK, when it's stimulated, it activates the osteoclast and causes bone resorption. The osteoprogerin that will inhibit the RANK and inhibit osteoclast proliferation and bone resorption. So the osteoprogerin also promote osteoclast apoptosis. So in ear, the osteoprogerin is found in abundance. That is, this is secreted by the fibroblast spiral ligament of the cochlea, and it is filled in the perilymph. And this osteoprogerin can be circulating in the entire aortic capsule through the perivascular channels, and that is why the bone turnover of the aortic capsule is less. So this biochemical balance is affected by certain genetic, hormonal, environmental factors. Initially, what is there? The osteoclast will come, the normal bone is removed, and and the connective tissues formed over the bone, and then those osteoblasts will come, and vascular spongiatic bone is laid irregularly, and this will become sclerotic. That is what happens in the otosclerosis, and initially it starts from the anterior part fistula antifenestrum and involves the anterior part of the stapes footplate, causing subluxation of the stapes footplate, and then it can involve the entire footplate. So depending on the stapedial otosclerosis can be classified. So initially the anterior involvement, that is the rim involvement, it can be anteriorly involved or posteriorly involved, and a circumferential involvement can happen. And the fourth one is biscuit type of otosclerosis, in which the otosclerosis foci starts on the footplate and it looks like rice grain or biscuit type. Then the last one is obliterative otosclerosis, that is the entire oval window and the footplate is fully involved. So why does this autosclerosis develop? That is etiology. So genetic factors. So genetic factors around age, loci of genes have been diagnosed that can predict the person to develop autosclerosis. It can also be associated with multiple genes like COL, A1, TGF beta, angiotensin 2, etc. And autosclerosis can be associated with other bone remodeling disorders like osteogenesis imperfecta. There is a syndrome known as Van der Hoef syndrome, osteogenesis imperfecta, blue sclera, and autosclerosis. Genetic factors there. Most patients who have autosclerosis will have a history of autosclerosis in the family. So most commonly it is inherited in an autosomal dominant fashion with incomplete penetrance. And we also don't know whether the genetic susceptibility is for development of autosclerotic foci or for the tendency of progression of the autosclerotic foci. Another etiology is a viral infection. That is, measles infection is found to be a cause for development of autosclerosis. The measles virus RNA have been detected in the staples food plates from the electron microscopic studies and IHC studies. They say that vaccination against measles virus protects against autosclerosis for some extent. Other causes are autoimmune disorders, some HLA related, cytokine inflammatory related, parathyroid hormone dysfunctions. All these are also related to development of autosclerosis. Then gender, it is most commonly seen in females. That is mainly attributed to the hormonal changes in females. But thing is, if a male and a female is having the same level of autosclerosis, the female will be having less amount of hearing loss due to the elasticity of the ligaments due to the estrogen. In females, the pregnancy tends to exacerbate. Person is having a tendency to develop autosclerosis or a genetic tendency is there, pregnancy will aggravate it. So there is something called histologic autosclerosis. That is, in autopsy, autosclerosis has been identified in the aortic capsule of many patients. In autopsy, that is histological autosclerosis, they may or may not have symptoms. So most of these patients may be asymptomatic. Symptoms occur only when the stapes food plate is fixed. This asymptomatic histological autosclerosis do not have a gender predilection. History is the patient usually present in the third or fourth decade. 90% of patients present before the age of 50 years. So they will present with history of hearing loss. So hearing loss is the most common complaint. And mostly it will be bilateral. 70% of patients will have a bilateral ear involvement. That is, both the ears are involved. The patient will say, initially 1 year only was affected. Now both the ears are involved. They will present usually late only. They will not present in the initial hearing loss stage. First, it will involve the fistula antifenestrum. Then it spread to the stapes, that is known as stapedial autosclerosis. Then it can involve the cochlea, that is known as cochlear autosclerosis. If it involves the cochlea, the patient will develop a sensory neural hearing loss also. If it is involving only the stapes, the patient will have a conductive hearing loss. So initially what happens is, it is involving the anterior part of the stapes foot plate. So there is slight subluxation of the stapes foot plate. This stage will cause hearing loss in the lower frequencies. So patient will have difficulty in hearing the lower frequencies. Later, it involves the entire foot plates and all other frequencies will be affected. So initially, patient can come with complaint that I am not able to hear or identify whispers. If somebody is talking very slowly, I am not able to identify. Another thing is, patient will not say that patient cannot hear in the little noisy environment. If the background noise is more, or in a patient will say that I can hear better if I am in a bus stand or in a railway station or in a restaurant when everybody is shouting, talking, I am able to hear properly. That is known as paracusis, we will see. Why is it so? It is because in a noisy environment, we tend to talk louder. So when I'm raising my voice, the frequency will be more. So the patient usually have a low frequency hearing loss, and the frequency of the conversation noise is higher. Patient will be able to hear better. So patient is hearing normally or even better in a noisy environment. That is known as paracusis, we will see. Also, there are other symptoms. Tinnitus can happen. Tinnitus usually happens when this autosclerosis involves the cochlea. From the stapes foot plate, it has gone into the cochlea. Then a patient will have tinnitus mostly. And it can be roaring type of tinnitus, constant sound in the ear. Tinnitus can also occur during an active stage, like there is active bone remodeling and active vascularized bone is being deposited. At that time also patient can have tinnitus. And patient also can have vertigo. Certain patients, there can be coexistence of autosclerosis and a Meniere's disease. So a Meniere's syndrome has to be rolled out because if there is an enlarged saccule, it is a contraindication for the surgery. The patient will talk in low volume, monotonous voices. I remember this because when I was doing my undergraduate, when my MBBS almost 15 years ago, my professor, my ENT professor who taught the autosclerosis class was talking in low monotonous voices in the beginning of the class. So it stuck me and it stayed with me. They'll be whispering and they'll be coming close to you and they'll be talking continuously in the same monotonous voice. That stuck to me. So I remember him today and I think this will help you also remember that. So how do you examine a patient with otosclerosis? What are the clinical examination findings? That is, when you examine to an otoscopy, usually there will not be any finding. You can have a normal tympanic membrane. Sometimes in an active lesion, that is osteoblastic activity is going on, it's otospongeosis. So vascularized bone is deposited, and at that time there can be hyperemia of the mucosa. Hyperemia of the overlying mucosa can be seen through an intact tympanic membrane over the promontory. That is known as Schwartz sign. It is usually seen only in 10% of cases. Most of the patients' tympanic membrane will be normal. Tuning for test will show a conductive hearing loss or a mixed hearing loss can also occur. Usually in Rennie's test, the bone conduction will be better than air conduction. Weber's test will be lateralized to the ear with the conductive hearing loss. That tuning for test I will explain in another class. So in this, remember that Rennie's test will show a conductive hearing loss where bone conduction will be better than air conduction. Weber's test will be lateralized to the ear with the more conductive hearing loss. Now, what investigation you can do? You can do a pure tone audiogram. So pure tone audiogram will show a low frequency loss if it is an early otosclerosis, low frequency conductive hearing loss. Otherwise, if it is a later disease, all the frequencies can be involved. There can be mixed hearing loss also. Bone conduction will show a dip at 2000 hertz. That is known as Heart's notch. It is not a pure bone conduction loss. It is mainly an artifact. It is because of the resonance of the external aortic canal and the ossicles are affected at that frequency. That is why at 2000 hertz you will get a dip in the bone conduction. Why we say it is a false loss or an artifact? Because once we correct the stapedial autosclerosis, once we do a surgery, this will get corrected. So the dip will be corrected. That is known as Heart's notch. Then another thing you have to know is what is a cookie bite audiogram. That is what happens is when the patient is having a cochlear autosclerosis, that is the cochlea is involved, patient is having a sensorineural hearing loss, the patient will have mid-frequency sensorineural hearing loss. That is, we record audiogram in 500, 1000, 2000, 4000 frequencies. If you remember, think about your pure tone audiogram graph. So patient will have 5 dB loss at 500 hertz, 10 dB loss at 1000 hertz, 15 dB loss at 2000 hertz, and again 5 dB loss only at 4000 hertz. So it will be like a U-shaped. That is known as cookie bite audiogram, most commonly seen in cochlear autosclerosis because the mid frequencies are affected more than the lower and the higher frequencies. But what about the tympanometry? That is impedance. So the impedance means the compliance will be reduced. Compliance will be reduced in the ear because the status is fixed. Initial stages of autosclerosis, you can have a normal impedance also, that is normal A curve also. When a patient is having A curve, you cannot say that the patient is not having autosclerosis. The typical tympanometric curve for autosclerosis is AS curve or a stiffness curve. Usually the stapedial reflex will be absent because the status is fixed, so stapedial reflex is absent. This helps you differentiate autosclerosis from a third window, like a superior semicircular canal dehiscence that can also present with conductive hearing loss, and the stapedial reflex will be present in the superior semicircular canal dehiscence. Also, there will be absence of the transient evoked optoacoustic emissions. That in this patient, the speech discrimination will be good. So the speech audiometry will show a good speech discrimination. You can also do a HRCT temporal bones. So this HRCT temporal bones can identify the sclerotic foci. There's a classification for autosclerosis based on HRCT temporal bone, which I'll be talking about at the end of the class. What is the differential diagnosis? You have to differentiate it from serous otitis media, telangiectasis, tympanosclerosis. Then there can be congenital stapes fixation, then fixation of the malleus head, in the attic fixation of the malleus head. What is the treatment? Treatment can be divided into medical and surgical treatment. Usually medical treatment is not much is available. There is something known as sodium fluoride. which you can give. Sodium fluoride has this osteoclast inhibitory activity, and also it neutralizes certain toxic enzymes that are released during the osteoclastic activity. So it is usually given in cochlear otosclerosis, any active otosclerosis, and it's during surgery. If there is an active otosclerosis present post-operatively, you can prescribe sodium fluoride. It is contraindicated in pregnant patients and in patients with renal disorders or patients having some skeletal fluorosis and intolerance to the drug. All this, the sodium fluoride is contraindicated. In patients with tinnitus, sodium fluoride is found to have some effect in reducing the tinnitus. Another drug that you can use is bisphosphonate, solondronate, risondronate. This will inhibit the osteoclastic activity. Then also supportive treatment like vitamin D, bioflavonoids. If there is a thyroid dysfunction, all this can be corrected. Then also you can prescribe hearing aids. If patient is not willing for a surgical correction, you can prescribe hearing aids for the patient. The surgical treatment for the otosclerosis is stapidotomy or stapidectomy. So what happens is just imagine like you have the tympanic membrane, you have the malleus, you have the incus, you have the stapes. Stapes is fixed, foot plate is fixed to the organ, it is not moving. So our main surgery is to make this move. That is, you create a small hole on the stapes foot plate and connect a piston instead of the stapes to the incus so that it moves and the hearing loss is correct. That is a basic idea behind the stapidotomy. Stapidectomy is complete or partial removal of the stapes foot plate and then insertion of a piston. So the most common performed surgery is stapidotomy. We can refer to the next upcoming video and learn about the steps of the stapidotomy, the contraindications, the indications, and the complications of stapidotomy.